Everyone, we'll have a small update to the agenda for the rest of the morning. We are going to postpone the general best practices update until the February meeting, so we'll be moving into the rabies vaccine section so that we can keep to our timeframes and make sure everybody makes their flights.
Okay,
but plan on staying later in February.
With that being said, we'll move to the rabies vaccine with an introduction by Dr. Fry.
Good morning. I promise this will be a little bit more simplistic than your last presentations. So we have decided to streamline our presentation significantly in the interest of time, and so I'm not going to go through all these slides, but I do want to introduce the committee to you and just update you on a couple announcements. So the ACIP members are Lynn Bata and Jose Romero on this committee, and the leads are Jesse Blanton and Agam Rao, who you will meet shortly. I want to thank all the liaison representatives and the subject matter experts for their participation in this group, and also our behind-the-scenes people, our CDC technical work group and subject matters experts. As far as terms of reference is concerned, I have 2 slides on this, and I just basically want to tell you that we are reviewing PrEP and PEP recommendations. The last overhaul of these recommendations were in 2008, and there were some PEP changes in, I believe, 2010. We'll be looking at all aspects as it relates to vaccines during our meetings. Sorry, I'm doing this in the interest of time. Okay, so our plan is to give you detailed information. We're going to give you some intro today on rabies and PrEP, but in the future we plan to have detailed information for you to vote on PrEP and probably October of next year, PEP. The announcements that I want to make, this is one slide and there's another slide. There is a current rabies vaccine and immunoglobulin shortage. However, this shortage is not significant enough to impact patient care, and we are told by CDC that no modification to current practices are needed and that anybody who needs vaccine or immunoglobulin can receive it. There's plenty around. It just has to be redirected from other companies. Our vaccines are Rabivert by GSK and Immovax by Sanofi. The Sanofi product is the one that is currently unavailable, but there is enough Rabivert to go around. There's also an issue with RIG, the rabies immune globulin. But it's an immunogam that has to be ordered directly from the manufacturer, but there's enough KEDRAB and HyperRab to fill in for gaps with immunogam. This announcement came October 21st, which I believe was Monday. We just learned about this. GSK is divesting the rabies vaccine Rabivert to Bavarian Nordic. But we are advised that there will be no issue, again, obtaining rabies vaccines. The vaccine will continue to be manufactured primarily at GSK's Marburg, Germany site until full production is transferred to Bavarian Nordic, and again, no immediate impact on supply. So next, I would like to invite Dr. Agam Rao to come up and talk about background information on rabies, followed then by Jesse Blanton, who's going to give us the intro to rabies PrEP schedule and serologic monitoring. Thank you.
Thank you, Dr. Rao.
Great. Thank you, Sharon. Okay, so rabies is caused by viruses in the genus Lyssavirus. It's an acute progressive encephalomyelitis that occurs worldwide and is nearly always fatal once clinical symptoms and signs begin. It's transmitted from infected mammals by bite, scratch, or exposure to saliva or neural tissue, and it is not transmitted by exposures to blood, urine, or feces of infected animals. Rabies is a neurotropic virus. It enters peripheral nerves, travels centripetally to the central nervous system, and then flows centrifugally to innervated organs, including the salivary glands. This process is illustrated here in this image. The incubation period after an exposure is weeks to months, and death typically occurs within 2 weeks of illness onset. Few animal species are reservoirs for rabies. Rabies virus variants are named for the animal reservoir species in which they circulate and are confined to geographically definable regions. Infections can be transmitted from the reservoir species to other species, and for example, a raccoon rabies virus variant could spread from a raccoon to a cat to a human. So the rabies virus variant does not denote the animal to which the human was exposed. It just denotes which animal is the reservoir. In the United States, canine rabies virus variant has been successfully eradicated. That leaves terrestrial or wildlife rabies, for which wildlife are reservoirs, and non-terrestrial rabies, for which bats are reservoirs. The map here on the right shows confined areas for skunk, raccoon, fox, and then you have mongoose there for Puerto Rico. And non-terrestrial or bat rabies, on the other hand, is endemic in 49 of the 50 states. Hawaii is the only state without rabies. Approximately 5,000 animals test positive for rabies each year in the United States. Exposures that have led to confirmed human cases of rabies can be broken down into domestic exposures and international exposures. Domestic exposures include during recreational activities. Occupational include veterinary and laboratory work. Contacts during everyday life include if there are bats in a home or a residence is in a wooded area with increased opportunities for animal-human contact. And then there's organ and tissue transplants that have also resulted in rabies cases. International travel can be both leisure and occupationally oriented. Dogs are the most important animal reservoir for rabies internationally. During 2009 to 2019, there were 25 confirmed cases of human rabies in the US, so 5,000 positive animals each year, but 2 to 4 human cases each year. Domestic exposures accounted for 17 of the 25, and international exposures 8. Most domestic exposures were due to bats, and most international exposures due to dogs, as you can see here. It's important to note that none of these were due to occupational exposures. Primary prevention involves avoiding animal exposures and vaccinating domestic and wild animals. Secondary prevention is where pre-exposure and post-exposure prophylaxis come in. Pre-exposure prophylaxis, or PrEP, involves a vaccine series. Over 15,000 people receive PrEP each year in the US. Post-exposure prophylaxis, or PEP, involves thoroughly washing a wound with soap and water and administering rabies immune globulin in a vaccine series. About 50,000 people receive PEP each year in the US. So in the red boxes here, you can see that a large number of people receive pre-exposure and post-exposure prophylaxis. The number of human cases are very few, but many people are getting these preventive measures. Moving on to factors that contribute to PrEP and PEP recommendations. The next slide is a little bit busy, but I'm going to walk you through some of the important elements. This is a table from the current ACIP rabies recommendations. Pre-exposure recommendations, including schedules and frequency titer checks that are listed here in the last column, are derived from the information in the other columns. And they are different depending upon someone's risk for rabies exposure. So the risk category is listed here in the first column. For example, at the bottom of the first column is the risk category with the least risk for rabies, and those are people in the general population. So no PrEP is needed for that general population according to the current ACIP recommendations. So as you go upwards in this table, in the first column, there's increasing risk for those categories. So infrequent, frequent, continuous, those are increasing levels of risk for people. and that corresponds to risks that are episodic with recognized exposures, episodic with some exposures that could be unrecognized, and all the way at the very top, you have continuous risk, which includes populations like research laboratory workers here in the third column. Recommendations for PrEP in the last column can be different for different risk categories. Moving on to the decision to administer post-exposure prophylaxis, it really depends on the type of exposure a person has. So is the exposure a bite? Is it a non-bite? For example, is it aerosol, organ tissue transplant, contamination of wounds or mucous membranes with saliva or neural tissue? Is the exposure to something that we wouldn't worry about, like urine, feces, blood? And then what is the bio-geo-behavioral risk assessment? Is the animal a reservoir species for rabies? What is the rabies epidemiology in the area? Was the animal showing signs of rabies? All of these weigh into whether or not a decision is made to administer post-exposure prophylaxis. And similarly, schedules and titer checks are also dependent on whether a person received pre-exposure prophylaxis administration, whether there were any deviations in the post-exposure prophylaxis schedule, and whether the patient has any other special considerations like being immunocompromised. So these last few slides were to try to explain that the pre and the post-exposure recommendations would be different depending upon people's risks and also other conditions. And then finally, going into the national and global rabies recommendations, the ACIP and WHO recommendations have changed over the years. Years and years ago, so this hash on the far side of this is intended to show that there's a huge gap in time there. But so years and years ago, the rabies management was different from the way it is now. There was impaired vaccine quality, decreased potency, increased adverse events. One of the vaccines was licensed for intradermal and intramuscular licensed vaccines as well. There were a large number of vaccines that were needed for post-exposure prophylaxis. And with changes in all of these, the recommendations have also changed. As recently as 2008, we had a 5-dose post-exposure prophylaxis intramuscular series. In 2010, the series was reduced to 4-dose series, and the impetus for that was a severe vaccine shortage that did affect patient care, and the evidence there was there for 4-dose series, and that recommendation was made and has stayed that way. In 2018, WHO reviewed new data that is out there, and made new recommendations, and in 2019 to 2020 is where we are right now, where ACIP is in the process of doing the same thing. So in this final slide, I just wanted to point out these are the vaccines and the immunoglobulin that are currently available in the US. Sharon already presented this, but you can see there's 2 rabies vaccines and there are 3 immunoglobulin products. And we'll have presentations about those in the future. And again, I do want to thank the same folks that Sharon mentioned to all of you, the Rabies Vaccine Working Group, as well as our internal CDC staff who meet regularly to discuss a lot of these issues. And I can take questions.
Are there any questions from the voting members? Any questions from the liaison groups? Yes, Dr. Maldonado.
Yeah, that's a really nice overview. Thank you. I was just wondering if you we're planning on addressing the global eradication work from WHO and how that might be phased in or out or affect supply around the world.
Yeah, so these recommendations are focused on the US population. And so the recommendations are really just, we have different considerations compared to WHO, so our recommendations may differ. Global eradication isn't part of the scope.
But it won't affect the supply, you said here.
Right, yeah, our supply is different.
Dr. Messonnier.
Hi. I just want to make sure I understand one of the points you made, which is the large number of people that are getting this. Is our interpretation of the large number of people getting it, none of whom have had disease, a sign that we think the intervention is so effective and therefore that's the right number? Or is the implication that a lot more people are getting it than you all think actually need it?
Yeah, it's probably both. As far as the cases that I showed from the last 10 years of the confirmed cases, none of those patients received pre or post-exposure prophylaxis. There is a lot of pre and post exposure prophylaxis that is going on, but we don't know whether any of that could be inappropriate. We're not, I mean, the ACIP recommendations exist. Whether or not people are following them is not 100% clear, but if they are, then we would assume that people are having exposures that fall into the risk categories, that people are following the different steps that I outlined here and determining that those are risky situations that deserve post-exposure prophylaxis. And pre is probably, veterinary students all receive pre-exposure prophylaxis, laboratorians. There's a large group of, there's 10 to 15,000 people who receive pre-exposure. Those are all appropriate, probably. Maybe some of the travelers maybe don't need it, but overall that pool is probably more representation of the need than the post.
Any other questions, comments? Dr. Hunter.
Just one comment. When I get a call from an emergency room about should they do it or not, I tell them to go to Jim Kazmierzak's bite about a bite. The post-exposure prophylaxis. The algorithm that's, if you just Google Wisconsin bite rabies, you get his thing. And I haven't even read to be honest, the ACIP recommendations, because I just use that as far as what I recommend to people. So I guess I just want to say that as a story that those kind of aids may be something that you should look at and make sure they're right. I think they're right. I hope they're right. Okay. Because that's what people are really using.
Sounds good. Yeah, we should do that. Thank you.
Any other questions or comments? Okay, very good. Thank you, Dr. Rao.
Thank you.
So we'll move on to Dr. Blanton with rabies PrEP schedule and serologic monitoring by risk category in healthy non-pregnant persons and special populations.
Well, that loads up, I guess, in the interest of time. Since this will be somewhat of a crib notes version of this presentation. And the slide sets were provided, and there are references to these information throughout there. So if you really feel a need to take a deep dive into some of the comments that I may kind of gloss over today, that's certainly available. Quite a bit of information to cover that gives a little bit more of a perspective of the pre-exposure prophylaxis schedules that are being considered by the rabies working group. But in general, the things that we've been considering is looking at the current classical vaccination schedule that's recommended by ACIP. This is the 3-dose vaccination series given on days 0, 7, 21, or 28. With subsequent recommendations around serological monitoring and boosters based on the different risk categories that Dr. Rao presented. But we also, given the amount of evidence that's been generated over the past couple of decades and the recent changes by WHO to recognize accelerated vaccination schedules, also wanted to look at some of those schedules, particularly the 2-dose accelerated 1 week. This would be 1 dose of vaccine on day 0 and 7. And then recognizing considerations around this on issues like routes of administration, how this would affect the different risk categories, immunocompromised populations, and also recognizing that this is a shift away from the FDA-approved 3-dose series that's in the licensed vaccines in the United States. Very quick picture on the overall changes in rabies pre-exposure vaccination, but in general, it took almost 100 years from the advent of Pasteur's vaccination to the advent of modern cell culture vaccines and the current pre-exposure prophylaxis schedules that we're all currently familiar with. And only recently, after evidence had been generated over the past 40 years experience with these schedules, the recognition of potentially accelerated schedules. This has all been largely through the development of more potent vaccines. And at the same time, also recognizing that while there's a good amount of information on the humoral response, and particularly neutralizing antibodies to rabies vaccine, we continue to have limited amount of studies and information regarding the cellular response. But this is why it's good to have a quick moment and talk about neutralizing antibodies as a surrogate of protection for rabies vaccination. The 0.5 IU per mil rabies neutralizing antibody level has been classically used as a cutoff limit of detection throughout studies for the past several decades. But it's important to point out that this is not a measure of protection, despite it being presented that way in some studies. But it's really just a measure of adequate response. And really in interlaboratory studies has really been largely recognized as being the limit of detection to reliably report rabies-specific neutralizing antibodies. And so while we definitely know that there's a strong correlation between antibody titer and survival, we also know from these largely animal studies that there's considerable variability in survival of animals above and below this cutoff. And so it's also quite a few animals that survive below this level, animals that do succumb to severe rabies challenge above it. And the only thing that we can definitely point towards is that individuals who have an adequate antibody response, generally recognized as above this level, and those who have an anamnestic response after a challenge or booster dose of vaccination are the best surrogates to indicate that they will survive rabies challenge. Another issue that we had to address and had quite a bit of discussion on in the working group is around the route of vaccination. It's important to point out that intradermal vaccination against rabies has been globally recommended since the 1980s. It was also recommended in the United States by ACIP between 1984 and 2008 when a licensed product was available for intradermal vaccination during that time period. It was removed after that product was no longer available. And the intradermal route has been found to be cost effective in all the modeling studies and studies that have been conducted, and dose sparing in supply limited settings, which represents largely the rest of the world. But that being said, there continues to be no licensed single-use intradermal packaging or multi-draw vials for rabies vaccination anywhere in the world. And the injection safety around large-scale intradermal administration of rabies vaccine has not been well studied, and that cost-effectiveness really becomes kind of, between intradermal and intramuscular, becomes somewhat moot as you have lower and lower patient volumes to the point where in very low-volume clinics, you're probably not gaining any additional cost-effectiveness over using intradermal versus intramuscular. But it's still a valid data and information to look at because we know from the many studies that have been done comparing intradermal and intramuscular that as far as neutralizing antibody kinetics, that intramuscular generally produces only slightly high at the full 1 ml dose, only produce slightly higher equivalent responses to the intradermal dose at 0.1 ml. And so we can still look at some of these studies to give us an idea of what the response may be over different schedules. Again, there are many schedules that have actually been evaluated in the literature. As I said, we're really focusing on the 0.7 schedule. And part of that's because there is actually a wealth of information on the primary response to this vaccine. In addition to the recommendations around WHO. But we know because this runs in parallel to the 07, 21, or 28 classical schedule, and many of the studies in the literature have evaluated serology at day 14 and 21 before that third dose is vaccinated. We can see from many of these that there's typically equivalent response amongst persons 1 to 2 weeks after a 2-dose schedule as there is at 1 to 2 weeks after the 3-dose schedule. But it's certainly not just about the issue with pre-exposure, definitely not just about the issue of the primary response. There have been some large-scale clinical studies, this one using the intradermal route, but this study found in general 100% adequate response, no difference between the classical and accelerated schedules at day 35. They actually found that 1 year later, the 2-dose accelerated schedule actually had a significantly higher geometric mean titer. But again, when a booster was given as a surrogate of rabies exposure or booster, no difference was found between the two different groups. But again, this issue around duration of immunogenicity is one that came up and was largely one that we felt wasn't discussed as much by the WHO in making their recommendations. And there's very few studies that have followed typically any further than 1 year. A few longer studies of 2 to 3 years and out to 10 years have mostly focused on the classical schedule. And a few have actually used a 2-dose schedule, but it was a 0.28. This is a schedule that was used historically in some countries. And so the focus has been really around these. However, one general trend that did come out is that looking at the titer at the primary response, 1 to 2 weeks after vaccination, was not a very good predictor of what the long-term immunogenicity would be in these individuals. And they found that it was generally much better to look at the titer at 1 year, and more even better to look at the response after a booster dose was given at 1 year as a predictor at 2 to 7 or even out to 10 years. And so this booster, the potential of adding a booster is something that led to quite a bit of discussion amongst the group. The considerable amount of evidence of the studies of even the limited studies that have looked at long-term response have really relied on a booster at 1 year to achieve these long-term responses. And so we can see even with the current classical schedule, we see drop-off of 20 to 25% of people not having an adequate titer greater than 0.5 at 2 years, compared to those who received a booster at 1 year who maintained very high level, with very few persons who drop below that cutoff again over multiple years. And this is seen not only with the classical schedule, but with other schedules looking at different dosages and routes. But one thing that has been clear in the studies that we have evaluated is that anamnestic response does appear to be essentially universal. The 60 some odd studies that we've started to look at as part of a systematic review, we've only identified a single report of an individual that did not respond to a booster dose of vaccine. This person was later diagnosed with B-cell lymphoma in the report. But as well, not just reacting to booster doses of vaccine, there are many cases and case reports of individuals who respond to natural infection and have an anamnestic response to vaccination and survive that exposure to rabies from individuals all the way up to, in the Amazons, from an effectiveness standpoint, mass vaccination of children that are being predated upon by vampire bats, where they've seen a complete reduction in the rate of rabies in those communities. That's not to say that there aren't pre-exposure failures in the literature. There is one classical example of this in 1982 in a Peace Corps volunteer that was vaccinated intradermally in Kenya. Was bitten by a dog and died 3 months after that. And this is the case that's classically been attributed to concerns about co-administration of chloroquine while receiving the pre-exposure series, specifically intradermally. And while the study has suggested that there were potentially multiple factors that went into this person having a lower titer and being at risk, we've continued, the general literature and surveillance has continued to not find any additional cases of failure of pre-exposure vaccination since this time. That being said, there are reports and studies that have identified inadequate immune responses to primary vaccinations, particularly amongst HIV-positive communities or cohorts. So quickly, what this means from our perspective in the discussions that we've had at the potential use of an accelerated vaccination schedule, at the risk populations that Dr. Rao spoke about earlier, we really kind of consider this as sort of the high risk, which would be your continuous laboratory, and the frequent category, which would be your veterinarians in endemic and zoonotic areas. So these are really people who have not only a high rate of exposure. We know animal healthcare workers have 300 to 500% higher rates of animal bites than the general population, but the persons in these areas also have much higher risk that exposure involves a rabid animal. So in these areas that are circled, we see typically 14 to 17% of the wildlife that are submitted for testing come back rabies positive. Around 1% of domestic animals similarly also come back positive. So this is a population that there is interest in maintaining higher titers with that sort of sense that a higher titer is a better correlation with protection. This also involves populations that may have unrecognized exposures, such as laboratorians working with high titer viruses. And so this is one where we feel that the evidence would suggest to maintain higher titers in this population over long time periods, that we may want to look at recommending that booster at 6 to 12 months to improve the likelihood of maintaining that titer. And similarly, if this is done, we feel that we could probably reduce the recommendations around serological monitoring for these populations as well. In addition, if you look at that sort of next tier in the moderate risk, these are the infrequent categories that Dr. Rao spoke about. These are, again, still have a very high rate of exposure events to animals and their occupational setting. But there's a low risk of rabies from these exposures. So again, in comparison to 14% of the population in endemic areas, we only tend to see about 0.5% of the animals that are submitted for rabies testing in this area that come back positive. And actually, there have not been domestic animals reported positive in some number of years from these areas. So this is, again, similar to actually current recommendations where we would not necessarily recommend that a routine booster is necessary, and that and as well as ongoing serological monitoring is not necessary, which is very much in line with the current recommendations for this group as well. Just wrapping up a couple of our special populations, immunocompromised populations, again, data is relatively scarce for this group. We really feel and in line with the current ACIP recommendations that risk reduction is the most critical, providing additional advice on exposure avoidance, appropriate use of PPE, and prompt health-seeking behaviors. Even if an accelerated vaccination schedule was used, it wouldn't necessarily be necessary to still recommend a larger dosage to this group, as opposed to recommending required serological confirmation of their adequate response, which is in line with the current ACIP for the classical schedule and the WHO recommendation for the accelerated. Similarly, for pregnant women, we know that there's, as a healthy population, very good response to the vaccine. As far as we're aware, there are no safety concerns related, but again, there's relatively scarce data in this regard. Focus would be on risk reduction, and in situations where occupational risks could be avoided or risk reduced and post-exposure prophylaxis is readily available, it might be considered to defer vaccination amongst pregnant women. But again, in situations where there is any kind of ongoing concern, recommend to go forward with pre-exposure vaccination. Very quick wrap up. We'll go into a little bit deeper dive in February when we present the systematic review presentations and the grade, and I can take questions.
Thank you very much for that presentation. Questions from the group? None? Anybody from, I'm sorry, was there?
Hi, Julian Ritchie with Sanofi Pasteur. I just wanted to provide a quick supply update. It was noted earlier that our ImaVax vaccine has been on supply restrictions, and the good news is starting tomorrow, it'll be back in supply, and we'll be shipping next week without restriction for direct orders. So just wanted to make sure we shared that new news. Thank you.
Thank you for that information. Dr. Talbot.
So it sounds like we're looking at reducing the number of prophylactic doses from 3 to 2. Is there a reason we're doing this other than WHO did it?
No, so yes, because there's evidence to suggest that this is an acceptable schedule to go forward. It's certainly, the WHO recommendation was out there, but we were looking at this from the evidence that had become available over the past 20 years. And the same sense that WHO looked at that evidence to come to their recommendations through SAGE. There are other certainly advantages to moving to a 2-dose schedule, particularly when you look at populations like travelers and volunteers that are more time limited in receiving the vaccine and getting more of those that are open, as well as issues around reduced cost by removing a dose of the vaccine.
Thank you. Dr. Hunter. Dr. Paling? Sorry.
All right, thank you. Thank you for this presentation. I'm looking at your special populations, and I don't see bats on there, but when we saw the data on the people who actually were exposed, it was predominantly in bats in the United States. So help me reconcile the two.
Yeah, and we'll certainly go into this more later in February. Generally, per the current recommendations right now for ACIP, any persons who are working directly with bats would fall into that frequent category, and so would either would go through additional serological monitoring, or in this case, would be recommended a booster.
Dr. Hunter.
So currently, there's no 6 to 12-month booster recommended. Do other places, other countries recommend a booster, or any recommendations anywhere for the booster? Would this be something totally new if that were what you guys brought up to us?
So currently, there's no recommendation in ACIP. Some countries not informally recommend it to veterinarians. There's probably not as much adherence to pre-exposure prophylaxis in most of the world. By default, a lot of these individuals, if occupational monitoring of serology is occurring, do wind up getting a booster, certainly by year 2 by our current recommendations. So that's probably where most of them are kind of being caught up, of those lower responders are in fact getting a booster 2 years later.
Dr. Kimberlin.
David Kimberlin, AAP, Red Book. What percentage of bats are infected with rabies?
In the general population, the estimate is around 1% amongst bats that are having some kind of interaction or contact with humans. So these are bats that are getting submitted for rabies diagnosis. That goes to 6 to 12%, depending on the region.
Other questions? Okay, thank you very much for your presentations, and thank you very much for streamlining them.
Thank you.
Next, measles. Let's see, Dr. Gastanowski.
Thank you for the invitation and for the opportunity to update you on recent measles activity in the United States. So from January 2018 through mid-October 2019, 1,637 measles cases were reported in the United States. This figure shows the number of cases by month of rash onset. As you can see, an increase in cases began in October of 2018, corresponding to the start of the outbreaks in New York City and New York State. Cases peaked in March and April of 2019, and we have seen a steady decrease in the number of cases in recent months. 2019 has been a challenging year. This table shows a few characteristics of this year compared to prior post-elimination years. We have had 83 importations, which is on the higher end of our usual numbers, and this partly reflects increases in measles globally. We have had over 1,200 cases this year, and this is the largest number of cases reported in the country in a single year since 1992, and since measles was declared eliminated. The number of outbreaks has also been at the higher end, 22 outbreaks, and except for a couple of outliers, no notable differences in the cases per outbreak and the duration of the outbreaks. This graph shows the age-specific incidence and burden of measles, as well as the vaccination status of measles cases in 2019. Starting at the bottom, like in previous years, most cases were unvaccinated or had an unknown vaccination status, 89% of all cases, and a minority are vaccinated. In the middle graph, you see that the burden has been concentrated in children aged 16 months to 17 years. And this is a bit on the younger side compared to prior years, and this is mostly driven by the outbreaks in New York City and New York State, which primarily affected preschool children. Finally, on top, you see the reported incidence, and it's highest among infants and babies 6 months through 15 months of age. And this is similar to previous years, and just represents a period within the population in which the pool of susceptibility is the largest. This map shows the location of cases associated to outbreaks reported in the United States in 2019. The size of the circle is proportional to the number of cases. There have been 22 outbreaks. The outbreaks are generally small and occurred in specific areas in the country. Of the 22 outbreaks reported so far this year, all but 2 have been declared over. And the largest and most prolonged outbreaks were the ones associated to New York. And in fact, cases related to outbreaks in New York accounted for 75% of the almost 1,500 cases reported in the United States since those outbreaks began in late September and early October of 2018. And this figure shows the weekly number of cases reported in this period. You will notice that there was sustained transmission related to these outbreaks for close to 11 months. And these outbreaks did threaten the measles elimination status of the United States. However, more than 2 incubation periods have elapsed since the last cases in those outbreaks, and those outbreaks have been declared over, and we have maintained elimination. As you will hear in the following presentations, these outbreaks occurred in under-immunized Orthodox Jewish communities. And in fact, the most sizable outbreaks reported post-elimination have occurred in a specific close-knit under-immunized communities in the United States. These are the 5 largest outbreaks in the US post-elimination. These outbreaks actually account for almost half of all cases reported after elimination. We had an outbreak in under-immunized Amish communities in Ohio in 2014 with almost 400 cases, outbreaks in a Minnesota Somali community in 2017, and an outbreak in a Ukrainian community in Washington in early 2019. So although the national coverage with measles vaccine remains high, it has been maintained at or above 90% since 1996. These outbreaks point to pockets of susceptibility in the population. So in summary, the highest annual number of internationally imported cases since measles was declared eliminated, and the highest annual number of cases in over 25 years was reported in the United States in 2019. Most cases were related to New York outbreaks, and transmission was driven by lack of vaccination. The reasons for increases in measles cases in the US include increases in cases globally. WHO is reporting a 300% increase in their cases in early 2019 compared to 2018, as well as continued importations and pockets of under-vaccination. And the recent large outbreaks that we have been seeing in the United States are a reminder of the need to close immunity gaps preemptively to avoid these outbreaks altogether. Thank you.
Thank you very much for that presentation. Questions? Dr. Hunter.
As I understand it, there used to be a seasonal fluctuation in the number of cases per month of measles when it was endemic in the United States that peaked in late winter, early spring. Mm-hmm. And I'm assuming that that's not necessarily going to apply to the upcoming several months because we've got elimination now, and that instead what would be more likely to cause another problem in the next several months would be importations. Is that about right?
Yes, absolutely. Basically, the seasonality has gone away since measles was eliminated because there's very few cases, and everything's related to importations. There's actually a little bit of a tendency to have importations during the summer season when people travel the most, so the seasonality has definitely changed.
Any other questions or comments? Yes, Dr. Maldonado.
Yeah, I have a question about the genotypes. Were you able to, do you have the data on the I didn't see it on the website, but do you know what the genotypes are for the circulating viruses this year in the US?
Almost all of them have been D8, I think over 95% of them. And this is a common genotype that has been circulating across the world, not specific to one area.
Hi, this is Manisha Patel. I'm the domestic measles epi lead. Just to add to what Dr. Gastanadui said is that with vaccination increasing globally, we have had, decreased heterogeneity in different genotypes. And so one of the steps that the CDC measles lab is going to be taking is to understand more sort of discriminatory genetic analysis among the various genotypes. So that's work that's happening among the reference centers. Throughout the US, there's 4, along with the CDC lab, so that data is forthcoming.
Thank you. Any other questions or comments? Yes.
Yeah, this is Patsy Stanchild from NAPNAP. I just want to comment that now is the time to have the attention and the urgency around this, to hear a 300% increase from WHO from 2018 to 2019, and having led, along with Lynn Bata and others from MDH, the Somali measles outbreak, trying to bring that to an end. Some of the misperception is, 1,000 cases in the U.S. right now. These little outbreaks that people sort of say, these are small numbers, we shouldn't worry. But this is exactly the time to worry because of how infectious and contagious this disease is. And I think if we don't keep getting that message out, it's not that we have 1,000 cases now, it's that prior to vaccine we had 4 million cases and 500 deaths per year. And we're seeing those kinds of large numbers of cases, percentages, and deaths around the world. And that will happen here if we don't continue our sense of urgency. So I think it's not about these small numbers of outbreaks, it's about the potential if we don't continue to vaccinate.
Thank you. Why don't we move on? Oh, go ahead, Dr.
I just want to say yes, and we'll tell you how we're trying to respond. But I also want to point out one thing that Paul didn't say, which I think is really relevant, is that there seems to be some misunderstanding of that 300% increase at WHO. Some of the countries that are having outbreaks are indeed conflict countries like Venezuela, but there's also ongoing measles transmission in many other countries and places where people don't think about the importance of getting their measles vaccination. And so the top 5 countries for importations this year, Paul, are?
Ukraine, Israel, Philippines, those are the top 3.
London is also in the top 5.
European countries has always been a source of importations for us.
You want those repeated?
Yeah, I just couldn't understand.
Dr. Sanchez would like to have those countries
My
repeated.
point is people might think about getting their vaccinations and checking CDC's yellow pages when they're going to countries that they consider to be less industrialized. But in fact, we have importations from London this year. And so, we've tried over and over again to emphasize to people the global threat and specifically the need for people to check on their immunization status before they travel overseas. But we're surprised over and over again that Americans seem unaware of that risk.
So we'll move forward to the next presentation by Dr. Blog on measles in New York State.
Good morning. So I'm going to take a deeper dive into the measles outbreak that took place in New York State from October 1st, 2018 through September 30th, 2019. My presentation will not include the outbreak that took place in New York State. Dr. Jane Zucker is going to talk about that after me, so I will concentrate on the lower Hudson Valley. However, characteristics of both outbreaks were very similar. The overwhelming majority of the measles cases that occurred in New York State were in undervaccinated, close-knit Orthodox Jewish communities. The total number of confirmed cases in the lower Hudson Valley was 407. There were 10 cases imported from Israel. These consisted of 7 cases imported in the first month of the outbreak alone, and 3 further importations, one in December 2018 and 2 in April 2019. Cases occurred in 5 counties. Rockland County, shown in red, had 312 cases. Orange County, shown in orange, had 57. Sullivan and Westchester counties, shown in yellow, had 19 and 18 cases respectively, and Greene County had 1 case. All of these counties have Orthodox Jewish communities, with Rockland's being the largest and the most diverse. However, though the outbreak took place in 5 different counties, it really was concentrated in several zip codes. The wildly dispersed geography of this outbreak was a challenge when working to control it. The county health departments ranged from small to large in terms of size and the population served. This made assisting with case investigations and contact tracing and monitoring of contacts difficult. It was also hard to get specimens to our public health labs, and we had to set up a relay system to get that done. This slide shows our epidemic curve showing the number of cases over time by rash onset. The colors reflect the different counties, with Rockland in gray, Orange County in dark blue, Sullivan in yellow, Westchester in turquoise, and Greene County in black. The arrows show the importation of cases, but the last arrow on the far right shows that the last date of rash onset was August 19th, 2019. Our epicurve has 2 main peaks. This could reflect unreported cases that occurred blunting the curve in the middle, or the increased travel that occurred before and during the Passover holiday in the spring. It also may be due to the outbreak affecting different Orthodox communities at different times. For example, transmission in one area was very active in the beginning, but virtually ceased later on where other areas took off. This table shows cases by age and vaccination status. 82% of cases had 0 MMRs, 5% had 1, and 4% had 2. 9% had an unknown vaccination status. Among those with 0 MMRs, 274 were 12 months of age or older and could have received an MMR. An additional 34 were 6 to 11 months of age and could have received an MMR in the outbreak setting. In terms of complications, 28 or 7% of patients were diagnosed with pneumonia. 28 were also hospitalized. However, not everybody who was hospitalized had pneumonia and vice versa. Of those who were hospitalized, 20 or 71% were children. And of those, 6 were admitted to an intensive care unit. All those admitted to an ICU were 7 years of age or younger. 2 preterm infants were born at 34 and 25 weeks gestation to women who had measles while pregnant. Both infants were born with congenital measles that was confirmed by PCR. There were no deaths or cases of encephalitis. The causes of this outbreak were multifactorial. However, the key factor was under-vaccination due to vaccine hesitancy. This community was targeted by anti-vaccine advocates who were skillful at disseminating misinformation in ways that resonated with this community. This combined with multiple importations from a large outbreak in Israel during holidays when there were large gatherings and family celebrations allowed for transmission of disease. Other factors included large families where measles could spread to all unvaccinated children, and families were often unwilling to report cases or seek medical care, allowing unidentified transmission to occur. In addition, positive IgM results were reported through lab reporting, usually done because parents wanted their children to return to school. By the time the labs were received, it was difficult to confirm that they were cases and too late for control measures. Communicating facts-based information about measles was a priority during the outbreak. Because electronic media was not a useful way to reach these groups, materials were developed in the form of flyers, posters, ads at malls and highway rest stops, and articles in local publications. Materials were developed in both English and Yiddish. 55,000 door hangers with information about measles were distributed to all homes in affected zip codes. Conference calls were held with women from the community, and many meetings were held with community and members and religious leaders. In recent years, the increase of vaccine hesitancy in Orthodox communities was recognized. After dissemination of an anti-vaccine pamphlet called Peach, the Hudson Valley Health Coalition was formed in one of the counties to address this problem. A booklet called Sim Gesund, which means be well in Yiddish, was created to combat the misinformation. In addition, the Orthodox Jewish Nurses Association wrote a booklet during the outbreak called Slice a Pie, or Making Pie Out of Peaches, which addressed all the points made in Peach about measles one by one. 90,000 copies of both pamphlets were printed and made available to households and provider offices. Outreach and communication with all types of healthcare providers was also a priority. This took the form of advisories, conference calls, and forums. More than 30 detailing visits took place in practices, urgent cares, and hospitals. The State Department of Health provided additional MMR vaccine to all practices that requested it, and also offered materials for patients and families that could be used in offices. Collaboration with a large federally qualified health center called Refuah was particularly noteworthy. They implemented screening procedures at the door, honed their infection control procedures, administered thousands of doses of MMR, and were a constant source of reliable information to the community they serve. They continue to work hard to address vaccine hesitancy among their patients. So from October 1st, 2018 to September 30th, 2019, providers in outbreak counties vaccinated over 84,000 individuals with MMR, a 77% increase from the same period during the prior year. Rates in the 4 most affected zip codes for children aged 1 to 18 years was 87.3 before the start of the outbreak, and by August 1st, 2019, increased to 98.3%. Vaccine was primarily given in private practices and FQHCs, though state and local health departments held clinics as well. Rockland County issued orders to exclude unvaccinated children not only from schools with cases, but also schools in proximity to cases. They required weekly attestations from each school that affirmed continued compliance with the order. Audits of most schools in the outbreak area were conducted, and several schools were fined for noncompliance. At the peak, Rockland County alone had approximately 6,000 children excluded from 60 different schools. Most counties with outbreaks excluded unvaccinated children from summer camps and conducted some form of camp audits. However, Sullivan County was at particular risk since in the summer their population increases to about 300,000 from their year-round base of 67,000. The increase is primarily due to Orthodox families from New York City who come up to the county to spend summer in groups of bungalows and to attend camp. All 300 camps in Sullivan County were audited in a joint effort between the county, New York State, and CDC. There were many lessons learned during this outbreak, but one main one was the ongoing need to address vaccine hesitancy and misinformation, and to find ways to do this with close-knit, culturally diverse communities. The second major lesson was the importance of partnerships between communities, healthcare, and public health, and also between local, state, and federal public health. And finally, we learned that religious exemptions had to go. In June 2019, New York State passed legislation removing non-medical exemptions from vaccine requirements for school entry. I hope my presentation gave you a sense of the magnitude of this outbreak. These are just some of the numerous individuals who helped. I want to give a particular shout out to our public health lab, the Wadsworth Center, whose scientists performed many, many tests, often during nights and many weekends, and also to CDC folks who provided tremendous support to us. Thank you.
Thank you for that very nice presentation. Questions from the group? Dr. Bell.
I'm just curious about sort of whether there was any heterogeneity among the different communities in terms of their acceptance. And in particular, I know that in some other situations, the position of the rabbi was important in terms of helping to direct the community in terms of their perspective about vaccination. And I'm just, obviously impressed about the size of this and wondering if the rabbis were all on board or not, or if people were just not listening to the rabbis as they might have in the past.
I think there was some of both. I mentioned the one community where the outbreak was very active, and then it virtually ceased after a number of weeks. And I think, though we didn't talk directly with that rabbi, we tried, but we couldn't. The information I got was that rabbi came out to his community and said, "Come on, let's end this." So I think it varies by location. Orange County, the community there is one community with basically one large group. The one in Rockland, there were many, many, many groups, and so it was obviously more challenging to reach out to the many, many groups. But yes, there was a great deal of variety between them. Refuah, the FQHC I mentioned, got several statements from prominent rabbis, both locally and in Israel, and posted them on their websites. And there was a lot of effort to do that sort of thing.
The suggestion has been made that we wait for Dr. Zucker to give her presentation on measles in New York City, and then bring them both up to the podium and discuss questions at that point. So why don't we move to do that now, because I think a lot of these questions have to do with that. Dr. Zucker, please, measles in New York City.
Good morning, everyone, and I want to thank ACIP for the opportunity to give today's presentation. So in New York City, our first case of measles as part of this outbreak had rash onset on September 30th, 2018, and this was in an unvaccinated child who returned from Israel. The outbreak was centered in two Orthodox Jewish neighborhoods in Brooklyn. So here's your map of New York City. They were in Williamsburg and in Borough Park. This is our epi curve, and this is by month with number of measles cases and then month of rash onset. Williamsburg is represented in red and represented 73% of all cases, while Borough Park is in yellow, and they were 19% of all cases. As Paul said, our outbreak lasted 9.5 months, and our last rash onset was July 15th. and we declared the outbreak over 2 incubation periods later on September 3rd. This is a similar table to what Deb had showed by age and vaccination status. And what's important is that 81% of our cases were under 19 years of age. So the age totals are on your right, and 19% were adults. For the vaccination status, 74% of our cases had no prior documented doses of MMR. 12% did have at least one dose of MMR, and importantly, 14% of our cases either had unknown vaccination status, and most of those were adults. So those were 92 of those 94 were adults. And the median age of our cases were 3 years, and the range was 1 month through 70 years of age. So now I'll turn to our outbreak response. And I just want to make a few sort of contextual comments beforehand. So the New York City Health Department we have a very long history of working with this community, and both the providers, different community-based organizations, whether it's sort of Head Start, WIC, child cares, as well as many of the partners that, whether they oversee yeshivas or other health sort of information. And so this really goes back to the 1990s when there were hepatitis A outbreaks in the community, and the department started providing hepatitis A. So again, I think that hepatitis A vaccine, so again, I think that kind of long-standing relationship was really very, very important. And because of several other health issues in the community, that we had actually hired a liaison for this community, a health liaison, to work with us, with the community and strengthen those relationships further. And we had actually established a health coalition for this community even before the outbreak started. And then I also want to just mention our registry, because I'm going to show you some data about that. In New York City, we're very proud of our registry. It's well-functioning, it's population-based. We have high compliance with mandatory reporting of childhood vaccines, and we have high data quality and completeness. And we've been a Sentinel site for well over 10 years. So this is just your 30,000 sort of foot view of the outbreak response. And really, we can talk a lot about just all the work that went into these particular activities, but we really focused on notification of exposed contacts. We were very focused on post-exposure prophylaxis, either with MMR within 72 hours if they were unvaccinated, or with globulin if it was indicated, and then recommending home isolation as needed. A lot of outreach to providers, both citywide and targeted, community engagement, which Dr. Blog had talked about. You can imagine the press releases, endless media interviews and articles. The Jewish press were fantastic partners as part of this response. We had numerous print ads that were put in papers to talk about the importance of vaccination and vaccine safety. We targeted social media that was important to the community. For example, WhatsApp. We would use and not Twitter. And then there were daycare and school exclusions. There was an emergency order requiring vaccination. And again, all of this was really meant to increase vaccination coverage in the community. And again, I think that the two outbreaks were very similar. And so my comments are going to really focus on some additional response efforts, to other than what was presented by New York State. So for contact investigation, we had over 20,000 named contacts, which went into our surveillance database. And these are the ones, that we knew about, not sort of more casual exposures. And many of these were exposures that happened in healthcare facilities. What was really important for us is that our surveillance database is actually connected to our immunization registry. So we're able to kick off a query out of that database into the registry and pull the vaccination data back into our surveillance, which was enormously helpful and really let us focus on people who did not have documented vaccination and really not worry about people who, again, we knew were immune by vaccination. Because of this large number of contacts, we actually had to set up a dedicated call center because we attempted to reach everybody, whether it was by phone or by sending a letter. And so that was one part of it. And just to skip a bullet, we actually had to put in a new structure within our response. So we actually had people that were dedicated to handling the household exposures, those the daycare and school exposures, as well as people who were just focused on our healthcare exposures. And we actually ended up assigning individual clinical staff to facilities to really help them manage that exposure list and also to try to put in place mechanisms to prevent additional exposures. And we, to help with that, we did actually station staff at one of the high volume facilities that were at the epicenter of the outbreak to help them with all the potential exposures and also to set up screening outside the facility to prevent more exposures. So on December 7th, this was 2018, we required exclusion of all unvaccinated students with medical and religious exemptions, as well as those who are not in compliance with the immunization requirements. And that was due to, again, increasing transmission and seeing transmission in the community. And these were really targeting the yeshivas that were in the affected zip codes. And we did conduct audits to ensure that there was compliance with these exclusions. And at the height of the outbreak, we were actually auditing 101 facilities in Williamsburg every week to make sure that there was compliance. And those programs that were not in compliance were subject to commissioner's orders and notices of violation, which would again fine the different schools. With follow-up in terms of noncompliance, there were actually 12 schools and daycares which were closed because either they didn't provide access to the medical or attendance records that we needed, or they had students who were not in compliance who were attending the program. And with, as you recall in the epi curve, we had the large increase in cases in March and in April, right when we had peaked in April. And so a public health emergency was declared. This is through a commissioner's order, and it required that every adult and child who lived, worked, or resided in Williamsburg and had not received the MMR vaccine, that they must be vaccinated. There were exceptions for people who had a valid medical exemption or who could demonstrate that they were immune. The Board of Health met the following week and approved this resolution. And overall, there were 232 individual summonses which had been issued in relation to this order. And the good news is that many of those were canceled because the person submitted proof of vaccination or proof of immunity. So I think the million-dollar question for everyone in the audience is whether these strategies were effective, right? So this is probably the most important slide, and this is our registry data. And so I'm focusing on Williamsburg and the youngest kids, since again, that was where we were seeing most transmission. You have number of doses, and then by week, the solid line is sort of the current time period compared to the dotted line, which was the 12 months before that. So if we go left to right, you can see we have the back to school rush. We have an increase in vaccination that happens every year. We declared the outbreak, and as you would hope, many children got vaccinated. We issued those school exclusion letters, and we see some peaks in vaccination. Again, these are the younger kids. If I showed you the same graph for the school-age kids, those peaks would be much higher. And then we sort of vaccination dropped off, and then we issued the emergency order. This is actually Passover. We can actually see that dip. So a lot of people got vaccinated, and now we're a full year later, and we're seeing an increase, in vaccination for back to school. So overall, in New York City, more than 188,000 MMR doses were administered during the outbreak period. This represents a 14% increase overall compared to the same period last year. Focusing on Williamsburg, again, the epicenter of the outbreak, there were over close to 12,000 MMR doses administered, and this was a 54% increase compared to the same period last year. And most of these vaccinations were administered by providers, the health department did not hold any clinics. So we estimated, again, based on our registry data, that coverage for children 12 to 59 months in Williamsburg increased during the course of the outbreak from 80% to 91%. So as you might imagine, an outbreak of this scale really had tremendous impact on the health department. There were over 559 health department staff who were at some point sort of activated in our system, like deployed to the measles outbreak. This is about 7% of our staff at the health department. At our peak, we had over 260 people who were actually working on measles. And, we talk about the number of cases, having 649 cases, but we conducted almost 2,300 case investigations. And all of those others were either didn't meet the clinical case definition or were PCR negative. And a very preliminary estimate of the cost of the outbreak is somewhere over $8.4 million. We actually implemented labor allocation codes so we can actually count up, how many hours and what the dollar amount was. So that's included in there, but it wasn't complete in terms of everyone filling out those codes. It also included costs for vaccine purchase, as well as the ads. So I think going forward, obviously we're staying vigilant. There's a continued risk of future importations. This year alone, we've had 12 measles cases that are not related to the outbreak. So it's not, right? We have the outbreak as well as we have to also address, additional importations. And we are working to implement the new legislation to remove religious exemptions. We are conducting school and childcare audits. We've been getting a tremendous number of requests to review medical exemptions. There are children who previously had religious exemptions that are now requesting a medical exemption. And so those are being reviewed by the health department when requested. We continue to track vaccine uptake and then also address vaccine misinformation. And we have actually launched a campaign in the city that to talk about the importance of vaccination, saving lives, and vaccine safety. And we are in the process of developing new targeted materials. And we know that we're in it for the long game. The outbreak may be over, but our continued work to make sure that we maintain high vaccination coverage, will continue. So thank you very much. And I just have to give a shout out. The staff at the health department were fantastic. And I'm really fortunate that I have fantastic staff in the Bureau of Immunization who work super hard. So thank you very much.
Thank you for that presentation. Why don't I ask Dr. Blog to please go up to the podium also, and we'll open this up for questions or comments. Go ahead, yes.
Thank you very much. I'm Yasmin Tyler Hill, representing the National Medical Association, a group that is, I think, at high risk for the anti-vax movement is the African American population. And my question is, what are the culturally competent community-based efforts that we're doing to target that population? And are we doing surveying? Because as I listen to this, I'm hearing on social media from my other African-American pediatricians in closed environments that they are hearing a lot more. They're getting a lot more families that are now questioning vaccines.
So we're going to put that question off until the next presentation, where it'll be partially addressed, and then we'll come back to that if you don't mind. If that's okay. Okay, thank you. Dr. Massignet.
I want to ask a question for both of the folks on stage, just to point out that overall immunization coverage in New York State is 97-something+%. In New York City, it's probably higher. So part of my question is, how did this happen that there are communities with such low vaccination coverage without you all knowing, given that you've been aware of the issue, you have outreach into these communities, but it feels like we got caught. Was it just bad luck, or was there a knowledge gap that we weren't looking closely enough at these communities at a level that would have allowed you to identify them in advance?
I think we were aware that there was vaccine hesitancy in these communities, but I think we did not understand the extent of it, to be honest. And it's making us want to look closer to not just this community, but to others as well.
Dr. Fry.
We've had, last measles outbreak was 2013. We've had varicella, we've had pertussis. We were actually, like the Sim-Gazent, like we had actually been mailing out documents, and trying to address vaccine hesitancy well before the outbreak. We were working with individual providers. After the measles outbreak, we did a lot of work. And there was a lot of frustration by the providers themselves about the challenges with getting getting the children vaccinated. The truth is we can't force vaccination, and I think we've really have heavily focused on both the daycare compliance as well as school compliance, that when we can capture kids in the system, we could make sure that they get vaccinated. So I think we were aware and working on the problem. But I think that in part it was, this was an incredibly complex outbreak, which I don't think fully came through. This was not one outbreak. This was multiple outbreaks that happened at one time. So, we had over 90 chains of transmission that were identified. So I think in terms of the bad luck part and the impact of what's going on in Europe with the multiple importations, I think that was also part of it.
Yeah, I'll also add that, religious exemptions were okay. And a lot of these kids in schools had religious exemptions. So even though we audited the schools, they weren't necessarily doing anything wrong or illegal.
Right. I think if I can just follow up with Deb, there were some schools that had 28% of their children having religious exemptions. So again, they were in compliance. And, that's the challenge. And if measles sort of got into that school setting, you could imagine, right, how, that really fueled transmission.
Dr. Sanchez.
So I'm intrigued by the number of cases in those less than 6 months of age. The recommendation is for 6 months of age or older to get vaccine. So were these mothers non-immune? They had not been vaccinated? I saw one of them, a couple were congenital. What was this, or were they premature that had not gotten passively transferred antibodies? So I'm intrigued by the measles in the less than 6 months of age group, and were there other risk factors associated with that in terms of no maternal protection?
I don't think we are able to entirely look at that question because we didn't necessarily, well, actually we did know the mothers.
We did.
Yeah, we did know the mothers. I don't think we've explicitly looked at that, what the mother's maternal status was. But the kids that were under 6 months of age often were in families where the kids were unvaccinated, and the older children all got measles, and that child got measles as well. Some were just exposed in the community. For the congenital cases, the mothers were for sure tested and they had frank measles, and the infants were tested after birth with PCR and serum, and then were followed over time.
And were these more severe cases in the less than 6 months? Do you know?
I don't know that I can answer that.
Okay.
Yeah, we can look at it. I don't have that offhand. There were lots of kids. Some of them were definitely admitted to hospital, but they weren't all of them. It wasn't that hospitalization was concentrated in that group. We did have children who we knew were exposed, and the parents did refuse immune globulin as well. So I think a certain portion of those could have been prevented.
Dr. Fry.
I just wanted to thank you for two very nice presentations, but also compliment you on an incredible amount of work. Well done. Thank you, ladies.
Dr. McNally. Ms. McNally.
Can you talk about how you handled vaccination in that age range of 6 months to 11 months, if at all?
It was primarily targeting the practices that see these children and getting them to offer it. That was the challenge, and getting the word out. We did target that information to parents as well. So, yeah.
So in New York City, we did issue recommendations that children 6 to 11 months of age in the affected communities should receive an early MMR. And we know that it happened. I don't have the numbers, but because we have the registry, we can actually see, what vaccination was in that younger age group as well. And we were able to track that to know that it was being implemented.
And I guess I'm wondering under the circumstances if it would be appropriate to include some sort of note in the schedule regarding an outbreak occurrence?
It's in there. Okay. Right? It's already in the schedule.
It is in the ACIP guidance for outbreaks, and so that was implemented. I mean, I think the other part of that was also the travel recommendations, because there's still a lot of travel back and forth, certainly during the outbreak, and even now, especially with the Jewish holidays. And so we've been heavily messaging the importance of vaccination for that younger age group as well.
Dr. Kimberlin.
David Kimberlin, I may have misunderstood. Did I just hear you say that one of the challenges was getting physician practices to offer MMR as part of the response?
To 6 to 11-month-olds.
That was a challenge.
Yes.
Because of...
Thank you.
Dr. Cieslak.
Thanks. To what degree was the vaccine hesitation in this Orthodox Jewish community a heartfelt religious conviction, as opposed to sort of some of the reasons that people more typically choose exemptions?
Okay, Deb is going to give that one to me. So, I will just say that consistently from the rabbinical community and the community that there are no religious prohibitions to vaccination in this community. And in fact, there's a sense of importance of vaccination to protect people who are more vulnerable. When you see what the religious exemptions were, they really were philosophic exemptions that were sort of couched in religious language.
Dr. Tyler Hill.
Yes. With that, and just a comment on the problem with the pediatricians, as a practicing pediatrician, supply chain is a major issue. And so getting vaccines, and I don't know if there was anything done in terms of supply chain, but my question is specifically about the second vaccine that those children need at 12 months or after. Have we seen any problems with getting those? Are there any concerns, again, about supply and being able to appropriately immunize those children who got the vaccine between 6 and 11 months?
Right. So there are no supply problems. We had no problems in New York City, I will say, with making sure that practices had as much MMR vaccine as they needed. And we were, made every effort to make sure that practices that may not normally, like urgent cares, we gave them MMR, for example, to be able to vaccinate people coming there to vaccinate adults. So that was not a concern. I didn't break down the data, but a lot of the doses that we administered, there were first doses that were being given, but a lot of second doses, because we also recommended that children under 5 who got 1 dose got their second dose early. And so we know that that was happening as well. And again, because of our registry, when the children who got a dose under 12 months of age, as long as they're 12 months of age and older and 4 weeks later, they will have a recommendation in the registry, and that was part of the guidance that we had given as well.
Yeah, I would just echo the same for New York State. We made a big effort to get vaccine in a regular flow to all the key practices in the communities that were affected, and it was very successful. All they had to do was call up and ask for more. So.
Dr. Bernstein, last question.
I was interested to know, with the state legislation, does that apply to homeschool and private schools?
Yes, private schools. Homeschools there's a bit of disagreement on that from the legal community, but basically it does not apply to homeschools, and even if it did, it would be very difficult to enforce. But definitely yes to private schools.
But just to add on to that, if homeschool children are coming to the school setting for exams, after school programs, they are required to be vaccinated.
Riding the bus.
Right.
So I don't want to interrupt the questions, but what we're going to do is we're going to go to Dr. Mbaye's presentation and then hold your questions. If they refer to this, we'll go back to it. But we'll let Dr. Mbaye present on Vaccinate with Confidence.
Good afternoon. I'd like to start by acknowledging our colleagues from New York. We are so thankful for your efforts to help stop these outbreaks of measles. Although the United States narrowly maintained measles elimination status, we are not out of the woods yet. These measles outbreaks highlight the continued threat of vaccine-preventable diseases in the United States and have led us to rethink our approach to protecting the public from outbreaks. The first measles case is too late. We need to build confidence in the immunization program to ensure that all of our communities are protected through vaccination. Today, I'll be talking about CDC's strategic framework to strengthen public trust in vaccines and prevent outbreaks of vaccine-preventable diseases. The good news is that overall vaccine coverage is high in the United States. Most parents are confident in vaccines and choose to vaccinate their children according to the recommended schedule. Over 94% of kindergartners have received 2 doses of measles, mumps, and rubella vaccine. While school entry requirements provide a safety net for ensuring school-age children are vaccinated, some younger children are left unprotected. National coverage of at least 1 dose of MMR is 90% by 24 months of age, but there is geographic variation in coverage rates. 20 states have less than 90% coverage. And as we saw in previous presentations, lower rates of vaccination in some communities can create a foothold for diseases to spread. In particular, close-knit, under-vaccinated communities are a key vulnerability. Each of these communities is unique, with distinct factors affecting vaccination, including isolation or insularity, access issues, distrust of public authorities, or localized misinformation. Myths and misinformation have always been part of the vaccine landscape. However, rapid dissemination and sophistication of misinformation present new challenges. While its impact nationally is unclear, misinformation plays a clear role in eroding vaccine confidence and reducing vaccination rates in some local communities. To address these challenges, CDC launched Vaccinate with Confidence, a strategic framework for strengthening vaccine confidence and preventing outbreaks of vaccine-preventable diseases in the United States. This strategy responds to the dynamics shared by recent outbreaks, including pockets of low vaccination in close-knit communities, the spread of compelling vaccine misinformation targeted at these communities, and the perennial issue of ensuring vaccines are accessible and easy to obtain. Vaccinate with Confidence advances 3 key priorities: protecting communities, using every tool available to find and protect communities at risk using tailored, targeted approaches; empowering families, ensuring parents are confident in their decision to vaccinate by strengthening provider-parent vaccine conversations; and stopping myths, using local partners and trusted messengers, establishing new partnerships to contain the spread of misinformation, and educating critical stakeholders about vaccines. Vaccinate with Confidence combines CDC's existing work with new investments and activities. To protect communities from outbreaks, we have to find the communities that are most vulnerable first. To do this, CDC is leveraging the 2019 Immunization and Vaccines for Children Cooperative Agreement to support awardee efforts to find and respond to pockets of low vaccine coverage in their jurisdictions. Use immunization information system data and small area analyses to pinpoint areas of low vaccination coverage and identify barriers to vaccination, and build immunization program capacity to effectively respond to outbreaks. Every parent wants to make the best decision for their child's health. To help empower families and ensure that parents are confident in the decision to vaccinate, we need to equip healthcare professionals with resources to have effective vaccine conversations. CDC is supporting partners to help vaccine conversations start earlier with parents of very young infants and pregnant women, reducing hesitancy and improving vaccine access at the nation's community health centers, and developing provider toolkits to address parents' vaccine questions during outbreaks of vaccine-preventable diseases. To stop myths, we must ensure that reliable information is not drowned out by misinformation, educate key stakeholders about vaccines, and engage trusted local messengers to provide accurate and reliable information about vaccines. CDC is working with social media companies to promote trustworthy vaccine information, educating state policymakers on vaccine safety and effectiveness, and engaging state and local health officials to advance effective local responses and community-based initiatives to misinformation and hesitancy. We've made progress. So far, CDC assisted states and cities to respond to the worst year for measles since 1992, developed state and local health department, healthcare provider, and camp toolkits, worked with key partners to get their perspectives on vaccine hesitancy challenges, developed a strategic framework to strengthen vaccine confidence, and funded new work by key partners to implement immediate efforts. But we still have more work to do. Our priorities are to leverage diverse data sources to find and protect communities at risk, expand resources for working with communities, build and foster a culture of immunization in healthcare practices, provide technical assistance to funded partners, strengthen communication messages, and further invest in our vital partners. These partners are key. Advancing CDC strategy requires a cohesive approach with state and local governments, as well as partnerships with stakeholders and providers. The pictures in these slides are a great example of partnership in action between the American Academy of Pediatrics and Self Magazine to accurately and responsibly portray vaccination. Creative efforts such as these are needed to promote the positive and vital role vaccines play in protecting children and encouraging confidence in the decision to vaccinate. Together, we can protect our communities, empower families, and stop myths. I'd like to acknowledge all of those who helped inform CDC's Vaccinate with Confidence strategy and all of you who work tirelessly to promote vaccination in your communities. Thank you.
Thank you very much for that nice presentation. Questions, comments from the group?
Do you want to answer the question from NMA?
Do I get to ask the same question?
Yes, go ahead.
So one population that I see that will be at high risk is the African American population because there's already a disparity in vaccine uptake in that population. And just sort of interestingly, I've been hearing on social media from closed physician groups that include African American pediatricians that they are seeing increased levels of vaccine hesitancy. So are we doing anything to, one, survey how much of that is getting into the community as a preventive measure? And then once we're doing that, what then would our tactic be using these kinds of opportunities?
Yes, certainly, as you mentioned, there's already been a lot of work that CDC has been doing to try to help remove disparities in healthcare and vaccination access. I think to specifically address your question about vaccine hesitancy, one of our key cornerstones of this strategic framework is really to help identify those communities at risk and then implement tailored, targeted interventions. So we really want to work with our state and local health departments as well as other partners to help them find communities at risk, such as the African American population, other cultural groups, religious groups, other language groups, for example, to find these communities and then implement tailored approaches. We know that there's no one size fits all, so we want to try to help develop tools to really tailor. And so certainly we are working kind of across the board, helping to identify some of these groups and helping our partners implement interventions.
And I'll just add to Dr. Mabay's comments. I think when we talk about community, I think one of the things that you're describing is a community that may not be geographically close-knit, but it may be a community that is digitally close-knit and still sort of sharing similar values and receiving similar information. And so the African American community is a group that we have also identified as being at risk for increased hesitancy. And we would love to work with NMA and other groups more focused both through religious partnerships with religious organizations as well as partnerships with you.
I think that would be excellent. One of the things that would help is any data or tools of how this is growing within the population, because after practicing for 35 years, it's something that I never heard of before. And now, all of a sudden, as I go back in these groups that I'm members of, I'm hearing this from our pediatricians. So it is growing, and we need to monitor how much is there to see where we are, to look at what we need to target to prevent this from happening. And yes, the NMA would love to work with you on this. Thank you.
Great.
Dr. Hunter.
So I would just ask, as an ACIP member and especially a member of a work group, of work groups, that as you're implementing vaccines, vaccinate with confidence, you also do evaluation that can give data to be incorporated in the evidence to recommendations process in the implementation, so that the way we craft policy options, when it can reflect what will actually work.
Thank you. It's a great suggestion. Thank you.
Other comments or questions? Dr. Zahn, sorry.
Yeah, Matt Zahn from NACCHO. I think you described it as investing in infrastructure to support at the local level. So to me, that means you have to spend enough money in your budget at the state and local departments that you have people who are in your immunization program and your communicable disease program to respond to events and to make sure that immunization records are kept in schools and to respond. At some point, there's a capacity, need here, and certainly at the local health department level, the loss of thousands of positions around the country in the last 10 years is not a small issue.
That gets to me, I guess. One of the things that we've really tried to emphasize this year, which I think NACCHO should hear us saying all the time, is that while national activities are important, this issue is going to be fought locally, and local public health, local AAP and AAFP and all of our partners like NMA are the front lines. And there are some things that we can do centrally, but in the end, every community is so different that it is going to have to be very local public health that's going to help us in this situation.
Any other comments or questions? All right. Thank you very much for these presentations. And now, would Dr. Santoli take us home with the vaccine supply update?
So, hi there. I have a very brief update for you. We're going to just talk a little bit about hepatitis B vaccine. In terms of pediatric hepatitis B vaccine, and we've had an ongoing issue with supply for quite some time, Merck has announced that they anticipate continuing to have a limited supply of this vaccine through mid-2020 and will continue to direct its limited supply to CDC to support utilization that's consistent with the current clinical guidance. Fortunately, during this time, GSK is able to continue to cover the supply gap using a combination of their monovalent and combination vaccine. Sometimes preferences for specific presentations may not be uniformly met, but supply will be sufficient, particularly the expected monovalent supply to cover the birth dose for all children and some use for the second and third doses. Regarding adult hepatitis B vaccine, with the exception of a limited release of vaccine available this fall, Merck will not be distributing its adult hepatitis B vaccine or the dialysis formulation through 2020. Dynavax and GSK fortunately have sufficient supply of adult hepatitis B vaccine to address the anticipated gaps in adult hepatitis B vaccine supply during this period. Again, sometimes presentation preferences may not be able to be met, but supply will be sufficient. And that's the update, and just a reminder that we update this page so that you can see the latest and greatest information about vaccine supply at any time. And thank you very much.
Thank you for that presentation. Are there any more comments or questions from the group? Dr. Fry.
I have one quick question. When we get these updates, they're always quite interesting and worrisome. I was wondering if, when we hear about these things, maybe this is not an appropriate ask, but I'll ask anyway. Are we able to have a reason why the supply is short or not? They're not manufacturing it. There's higher priorities. There's competition at the pharmaceutical plants, whatever the situation might be.
So that's a great and very expected question. I will say that we defer to the manufacturers to talk a little bit about the reasons why. Generally, the way we manage these issues and the position that we are privileged to be in is that we receive confidential information. We sometimes understand a little bit better the whys, but what we use that information for is to manage the situation, to speak confidentially with other manufacturers who may be able to help mitigate the problem. And that's sort of the level at which we operate. So here, basically, I want you to understand exactly what's out there and what the situation is, but the whys would not normally come from CDC.
So if there's no further business and there's no objection among the committee members, the meeting will be adjourned. No? Okay. There being no objection, the meeting is adjourned.